ונעבור להרצאות לזכרו של פרופסור הנרי נויפלד, ונתכבד להזמין את פרופסור רוזנמן להציג את המרצה הראשון.
The first Neufeld lecture will be delivered by Professor Alec Vahanian. Professor Vahanian is the director of Cardiology Department at Hospital Bichat in Paris. He was the president of the French Federation of Cardiology. He carried a wide range of activities in the European Society of Cardiology and is well known to many of us as a good friend and a great teacher. For many years, Professor Vahanian is known as one of the leading experts in valvular heart disease. He chaired the European Task Force on Valvular Heart Disease and is the lead author on the recent European guidelines. It is a great honor for me to invite Professor Vahanian to deliver this lecture, a critical review of the EACTS guidelines on the management of valvular disease 2 years after the publication. Please, Professor Vahanian.
So, Professor Rosenman, dear esteemed colleagues, presidents, and friends. First of all, I'd like to say that I'm extremely happy to be here, because you invited me not for my scientific recognition, but mostly because we are friends. And I'm really very happy to see all people, but real good friends like Ivy and others in this environment. And Batya was always present, supportive, helpful. And my friend from Aficardio and others. So it's a real pleasure. But it's also an honor because I learned about Professor Neufeld and I know what he did and his achievements are great. So I try to discuss with you this topic of the EACTS guidelines on the management of valvular disease 2 years after the publication. In point of fact, I'm highly conflicted in this domain because you can see that I'm one of the parents of this document, and it is a multi-parental effort, and you see we have cardiologists, we have surgeons, and we have almost only friends in this domain, but it's a document. And in order to discuss what happens 2 years after, my friends from ACCHA were extremely helpful because they pushed and, they speed up the publication of their document in order to, to have some sort of comparative data, comparative document to further discuss this domain where the level of evidence is always C, is almost only a matter of consensus between friends. So, let's try to go through this issue by discussing only a few items, discussing the EAC guidelines, ACC-AHA counterparts, and a little bit of evidence if we have any. Let's start by patient evaluation. And in our document, we stress and reinforce, and I was a bit sad to listen to what happens about PCI, because we reinforce very strongly the fact that heart team approach is key. Surgeons, cardiologists, anesthesiologists, imaging specialists, sometimes others, should collaborate, work together. It's not sufficient to have a building with 2 surgeons and cardiologists. They should speak together, work together, and reinforce their collaboration to treat the patient at best. And this is a very strong argument in favor of center of excellence. Now, I'm an old clinician, look at my beard, so I'll be quite simplistic. And in this document, we stress the fact that we have to go stepwise across this slide. First, to assess the severity of valve disease, and Pat is going to discuss tomorrow, this afternoon, very difficult domain of low flow, low gradient AS. Not always easy. We are dealing with elderly patients. We should know if they have symptoms and if the symptoms are related to the valve disease. But more importantly, we are dealing with old patients with many comorbidities. And we have to know about life expectancy and the risk between surgery, intervention, and medical therapy. And in our brain of cardiologists, we're always extremely feared about the risk of intervention. We completely forget that in the same patient, the risk of nothing, the risk of medical therapy, is much, much higher. Then we should, of course, listen to the patient and look at what we are able to provide in terms of care. Well, I think that we should acknowledge that the ACTS team, cardiologists and cardiac surgeons, were the first to state very clearly that for evaluation of the risk of intervention, we should not rely on a non-magic number coming from a score like STS or Euroscore. We should work as a hard team and provide a global assessment of the risk in addition to a combination of score. And we are quite right. Look, here is a newest score, Euroscore 2, good discrimination, but the calibration is still very poor in high-risk patients, who are the patient of most interest for us. And you see on the right part of the slide that in the patient so-called low risk, Euroscore below 15%, in point of fact, many of them, 80% of them, do have porcelain aorta, impossible to operate, severe liver disease, frailty, etc. So we underestimate the risk by using this score in isolation because they do not catch up several comorbidities. And a friend from the ACCHA provides this rule, this recommendation. They said that if you don't have STS score over 4, for example, look at frailty. And look also at the major organ system impeachment, and look at the specific procedure impediment. That's very important. That is a global approach of the problem, including new things like frailty. We have to work very hard on that. One example coming from Europe. I encourage you to read European Heart Journal, of course, and especially this editorial from Patrick Serrois. He looked at some data presented from Bern, where a colleague showed what happens if you do TAVI in patients at intermediate risk, according to STS score 3 to 8. In point of fact, when the heart team looked at this so-called intermediate risk patient, they found anatomical reason to avoid surgery in 3%, major comorbidity not catch in the score in 5%, and finally they judge the patient are at excessive surgical risk in as much as 43%. So, after the heart team discussion, more than half of these patients were not intermediate risk, they were high risk or even inoperable. Also, we learned that we have to remain doctors and treat a patient, not a disease. We can provide surgery, we can provide percutaneous treatment, but we should remain with medical therapy in patients really too sick, with no life expectancy, where any intervention will be futile more than utile. And finally, we have a lot of work to do. Here we should pay homage to the Spanish colleague who ran a prospective survey in patients over 80 years of age with symptoms severe aortic stenosis. And look, now we have still half of the patients who are not considered for any intervention. It may mean that they feel that there are too many patients who are futile. It may mean that the message of the need for intervention is not there. So now move on to aortic stenosis. Medical therapy, the statement was quite clear. Today, no medical therapy is able to improve outcome. But we still continue, and we have to continue, research on different targets. We fail with statins probably because we treated patients too late. We have to reduce the effort treating the patient earlier on with other agents, maybe combination of agents. Now let's look at the indication for aortic valve replacement in patients who have symptoms. The two new things in these guidelines are in bold. Surgery should be considered in high-risk patients where the heart team thinks it's better to go for surgery. And also we discuss specifically, but Pat will discuss that this afternoon, surgery should be considered in symptomatic patients with a terrible entity of low flow, low gradient, and normal ejection fraction, but only after careful confirmation of the severity. And a friend from the US made exactly the same statement. So evidence is not that much, but the two groups, on one side and the other of the ocean, came with exactly the same level of recommendation. In point of fact, here it's very difficult. You know, I'm only interventionist, but this entity is terrible. First of all, we have to get rid of the mistakes, of the error in measurements, and then we have probably to pay more and more attention to the calcification and use more the CT in this patient, but Pat will discuss that. Then TAVI. TAVI is a big thing. TAVI, we strongly stress, and our US colleague did exactly the same, the importance of the multidisciplinary heart team. We stressed also that TAVI should be performed only in hospital with cardiac surgery on site. Should say that a couple of days ago we are at the German Society of Cardiology, and I'm still alive, but I had to defend this concept. And I think it's very important to have cardiac surgery on site, firstly for patient selection, second for better performance of the procedure, and third for the follow-up of the patient. Then we wrote here that TAVI is indicated in patients with CVAS, severe symptoms, judged by a heart team as inoperable if they do have a sufficient life expectancy in terms of length and quality. Then we said that TAVI should be considered in high-risk patients where the heart team prefers to go to TAVI. Friends from the US did exactly the same statement, exactly the same level of evidence. What is the evidence? What are the data, the new data? Well, over 100,000, maybe 120,000. Prosthesis, TAVI works extremely well. Still, there are safety concerns. Mortality, stroke, maybe not that high, but still there are vascular complications. Paravalvular leak, of course, it's a problem. We have to learn how to evaluate these leaks and to properly assess their importance for prognosis. And partner trial gave us the first very strong evidence to say that it's better than medical therapy in patients inoperable and non-inferior to surgery. And during the ACC, this trial was presented, the CORVAL, suggesting that TAVI is superior to surgery for survival in high-risk patients. Is it sufficient to change the guidelines today? I don't think so. We have to wait a little bit, but probably it will move in this direction. Follow-up, we have 6 years follow-up, and you see the attrition in the survival curve due mostly to comorbidity. And now, for the first time, we have a risk score for TAVI, because it's good to know what is the risk of surgery. It's better to know, to balance the risk between surgery and TAVI. And my colleague, Dr. Jung, from the France 2 registry, was able to build this predictive score. And you can see very briefly that most of the parameters in this score for 30-day mortality are related to comorbidity. So patient selection is extremely important. So this score is quite good for calibration. Unfortunately, discrimination is not perfect, is only moderate, with a C-index around 0.6, which is slightly superior to all the C-index of Euroscore, STA score in the same patient, but still imperfect. And here there are probably many reasons, maybe not enough patients, even if there are thousands of patients, probably due to the fact that more than comorbidity patients will die between day 1 and day 30, and most importantly, because with a score, even very sophisticated score, we cannot catch up all the comorbidity parameters in this very heterogeneous population. So are we going to expand the indication for TAVI in extremely high-risk patients? No, because most of the patients will die of non-cardiac cause between 1 month and 1 year. We should be really more selective. Another very interesting study coming from Bern, once again, is about the functional decline. And this group nicely showed that after TAVI, 1 out of 5 patients will have a functional decline at 6 months. And the highest predictor of this functional decline is high frailty index. So we don't want to do TAVI to have a patient with functional deterioration after the procedure. So here again, frailty is a very important player. We should include it more and more in our guidelines. Are we going to treat all the patients? Intermediate risk, low risk? Well, that's a question. And there is a trend. Even in my country, there is a trend, and you see that the Euroscore is going down and down across the years. What data do we have? We don't have any randomized study to support the use of TAVI in intermediate risk patients. We have this retrospective study with some matching of the patient suggested that in intermediate risk, according to surgical score, the risk is the same after 1 year. but in the ESC guideline, just as in the ACCHA, it was clearly stated that TAVI should not be performed in patients at intermediate risk for surgery, and trials are required. Trials, we are very happy because within a few months, I think we are going to see the results of the PARTNER 2. So TAVI is also progressing, maybe a little bit slowly, in Europe, and a British friend who is leading the show are going to run their own trial in intermediate risk patients with a 1-year mortality, and should be stressed that this study is funded by the British Foundation. Now, what about the contraindication for TAVI? In our document, we wrote in the back below part of the slide, relative contraindication, bicuspid. Are we going to treat bicuspid patients? Well, we have relatively few data, less than 100 patients reported in peer-reviewed paper. A registry is ongoing. It shows to be feasible with satisfactory long-term results. What about the durability? Well, we don't know. It should remain, in our opinion, a relative contraindication for TAVI and be proposed only if there is a strong clinical incentive. What about coronary disease? Very frequent. The data are disappointing today. Series are highly heterogeneous and discordant results. There are several options. The option which is the most popular is to do TAVI alone in patients. Others are treated by PCI at a distance, 2 weeks, 3 weeks, in selected patients. Sometimes reconsider surgery, of course, never give up. And what we wrote in the guidelines, the same in the ACCHA, in patients with combined CAD and aortic stenosis, we should individualize the treatment as regards chronology and as regards the patient. There is a randomized study just started, initiated by Martin Thomas from London, which will randomize between PCI and nothing, and we'll see what will happen after 1 year. But it's good to write guidelines, but what about the feasibility, what happened in real life? And you see that in Europe, in Germany, TAVI is going up, even in France going up, but you see that in Ireland, in Portugal, it is going down. Why is it so? Because the problem of economics, the GDP product spent for healthcare, and also the source of healthcare funding. We should always remember that. Now, what happens to patients who are asymptomatic with AS? Here we have a couple of indications in italics, and you see that the indication rely on measurement of Vmax, on the degree of calcium. There are 2A, 2B, and our friends from the US have slightly different threshold. We say 5 meters per second, they say 5 meters, we say 5.5. It's minor difference. Grossly, there is an indication, is very selected patient with low risk. We do agree. Mitral regurg. Well, I think that at ESC in 2007, we're the first to clearly split MR in primary and secondary, and now it is the case in both sets of guidelines. Primary is one animal, the disease is a valve, the other is a secondary, the disease is a ventricle. Both we stress that mitral valve repair should be the preferred technique when it is expected to be durable. It's good to say that, but even in the US, you see not 100% of the patients get repair, and you see the average number, the median number of mitral valve operations per surgeon was 5. So it means that there is a lot of things to be done, and this paper, once again, European Heart Journal, nicely stressed the fact that we need more expert centers to treat a patient with Barlow, a young patient, an asymptomatic patient, a patient with very diffuse valve disease. Now there is still a continuing debate, and here there are two papers from the 2010. Early surgery, the Mayo group recommended for degenerative mitral surgery, treat almost every patient. That's good if you have super expert surgeon and if you cannot follow the patient. But in Vienna or in Colombia, people are pleading in favor of watchful waiting if you can follow up very carefully the patient. At ESC, the recommendation for asymptomatic severe primary MR are here, and you see that we move slightly forward, we slightly expanded and put a 2A indication for patients with flail, normal LV function, low surgical risk, and ventricle slightly enlarged. In the, I'm sorry for this slide, but in this thing you see that US colleagues completely agree as regards symptomatic patient, and are slightly more optimistic, pushing a little bit more for early surgery in asymptomatic, but the difference, once again, is very mild. As regards secondary in the EAC guideline, we said that surgery is indicated if you send to cabbage the patient and he has a severe MR and LV function is not dramatically depressed. We also reinforce the message that probably we should consider surgery if the patient has moderate MR, even more so if the exercise echo shows dyspnea, chest pain, elevation in pulmonary pressure. And as regards a patient with very low ejection fraction who cannot be operated on, we put a 2B. But a friend from the US were a little bit more conservative, and they put only a 2A for patients with chronic severe MR who are undergoing cabbage or AVR, but in point of fact, they do not differentiate between the level of ejection fraction. So let's say they are a little bit more conservative here. But in point of fact, if there are slight differences, it's because we have very weak data in secondary MR. Look at what we have to assess the prevalence of secondary MR in patients with heart failure. Theories are highly heterogeneous as regards the level of ejection fraction. They include patients with ischemic disease and patients without ischemic disease. And the assessment of severity is done by grade 1 to 3 or by ERO, and there are a majority of severe, majority of moderate. The data we are unsatisfactory. And the data we have from surgical results are unsatisfactory. Many people quote this STITCH trial where there is an effect which might suggest that the line in green is better than the line in red. It means it's probably better to add on mitral valve repair to patients when you do cabbage. But in point of fact, it's only observational data, even if prospective, because the decision to treat was left to the individual surgeon. So it's not zero, but it's not a sufficient proof. We need more data in the field of secondary MR. Percutaneous technique, edge-to-edge technique, fantastic thing. In the guidelines, EAC guideline on heart failure, I think that is the best statement to me, nicely worded in good English. In patients with an indication for valve repair, but judged inoperable or at unacceptably high surgical risk, percutaneous edge-to-edge repair may be considered in order to improve symptoms. In the valve guideline, we said grossly the same thing, and we propose to do it only in very restricted indication in patients with severe primary or secondary, judged by the heart team, 2B and C. In the American guidelines on heart failure, it's written that transcatheter or mitral valve surgery in function in secondary is of uncertain benefit and should be only considered after a good discussion, 2B and level B. But on the guidelines in valve, the statement after the FDA discussion is that it may be considered, so always 2B, only in symptomatic patients with chronic severe primary MR. So you feel here that there is a somewhat a little bit of difference. Everybody is cautious, maybe consider. Everybody puts forward heart team approach, but the sort of MR is slightly different. What sort of data do we have? Now there are thousands of patients treated, maybe 15,000 now, but the evidence is very limited. One randomized trial, less than 300 patients, mixed of primary, secondary, good safety, and now we say good safety and good functional result up to 5 years, but more residual MR. The rest is only registry. Good registry, but still only registry, mostly secondary MR, follow-up limited to 1 year, and we know that the patients feel well, but they still have MR. So these data are probably not sufficient to build a good evidence, and we need more data. And this trial will run in heart failure patient, severe MR, low ejection fraction, optimal medical management and randomization between edge-to-edge and medical therapy. Please enroll your patient, if you can do so, in Reshape in Europe, in COAP, and if you are French, you can enroll in Mitral. We need these trials. Now let's move on to valve prosthesis. Very important valve prosthesis. 1/3 of the patients we see in outpatient clinics have a valve prosthesis. And everybody on both sides of the ocean agrees. that we should discuss with the patient will do the final choice. And it is very important in both sets of guidelines. But now, the patient know about the TAVI and the valve in a valve. And they say, well, doctor, I don't want any more mechanical prosthesis because then you can come back and put another one without surgery. In the EACTS guideline, we were conservative and said that it cannot be considered as a valid alternative to surgery except in very high-risk patients when the heart team decides to do so. Which sort of data do we have? Well, here Dennis Veer should be acknowledged because he's running most of this registry, but the number of patients in the registry is still small, mostly in aortic position. It shows it is feasible, good success rate, good improvement, but there is some risk in aortic position. You may occlude the coronary or have some other hemodynamic problem. We need more data. Large study, different prosthesis, but if it comes to be true, it will completely change the thing and we'll be able to put bioprosthesis in 90% of the patient. Antithrombotic therapy. Both sets of guidelines were very clear. Oral anticoagulation is recommended lifelong for patients with mechanical prosthesis. But at the SC guideline, we were a little bit cautious about the new agents. And we wrote only one sentence: the substitution of vitamin K antagonists by direct inhibitors of factor 10A or 2A is not recommended in the patient with mechanical prosthesis because specific trials are to be done. But it was done in practice. It was done in the US, it was done in Europe, ended up with catastrophe. And our friend Franz Vodevers presented during the last EAC annual congress the result of the real-line trial comparing Dabigatran with common antivitamin K agents, and it was very disappointing. More bleeding with Dabigatran and not less, even slightly more, thromboembolism. So it's an issue which led to the decision from the European Medicine Agency Committee to say this agent is now contraindicated in patients with prosthetic heart valves requiring anticoagulant treatment. And in the American Heart and ACC guidelines, you ended up with exactly the same treatment statement: harm, harm, harm. So we need more trial. Research should not stop there. And if there are friends from the industry, please help us in this domain. What about the indication for antithrombotic therapy? I'll try to go fast now. What about aspirin? We are still fighting a little bit on both sides of the ocean. For us in Europe, we are relatively restrictive. We say low-dose aspirin should be given only in selected patients, those with concomitant atherosclerotic disease or those who had thromboembolism. But in the US, it is a wider indication, and it is recommended to give aspirin on top of Coumadin in all patients with mechanical prosthesis. I should say that we have no new studies, and I cannot understand this difference, but still there. What about the anticoagulation in patients with bioprosthesis? And look at the EACTS guideline. Oral anticoagulation should be considered for the first 3 months after mitral or tricuspid, and low-dose aspirin should be considered in aortic bioprosthesis. Exactly the same statement in the ACC AHA guideline, despite the fact that we need data. There are very few data. There are conflicting results, but still the consensus, always the consensus, ended up with the same recommendation. Now, what is the conclusion of all this discussion? We are pushing for heart valve clinic. Here is a paper recently published by Lancelotti and Rosenek pleading for this heart valve clinic. You need this sort of heart valve clinic with expertise in valve disease to screen the patients early on and to treat the patient at a later stage. It will be very good for the patient. It will be very good for clinical research. That is the way to go. And the friend from the US had exactly the same statement. Is that so important to stress and stress again? It's in favor of doing TAVI only in centers with on-site cardiac surgery, even more true for mitral intervention. The optimal care of patients with complex valve disease is performed in centers who can provide all the available options. You are not keeping the patient for intervention because you cannot do surgery. You're not keeping the patient for surgery because you don't know about intervention. the best solution is provided for the patient, not for the doctor, and there is a plea in favor of the development of heart valve center of excellence. So, dear friends, we are coming to the conclusion, and the first conclusion is really on both sides of the ocean, recommendations are consistent in most cases. We have no evidence, but we are bright people. We speak together. There were exchanges, and several of us were part of both sets as reviewers, as writers. So we ended up with consistent message. There are some discrepancies, but only on very focal and low-grade recommendations in domains where evidence is lacking. Both sets of guidelines put a lot of emphasis on the importance of shared decision-making using a team approach, re-stratification for individualized approach, and development of heart valve clinics and center of excellence. But we have to work. In the future, we have to work in basic research to find the medical therapy to prevent the progression of AS. Epidemiology, we have to learn to have the good data on epidemiology of secondary MR. Our friends, the surgeons, they should improve their surgical techniques in mitral repair, in aortic repair. Well, they have to work on that. And we have to carefully evaluate the percutaneous technique. So, now that the EAC loop of knowledge, pushed by Martin Simmons, we have the guidelines. Now our duty is to educate the friends based on guidelines. Here we are. We have, you can go to this website, of course, and we have several tools. In order to better implement the guidelines, we have these guidelines and practice tracks. It's a sort of pre-arranged merge of session during the EAC Congress on the guidelines. On valve disease, for example, from top to bottom, big guideline session, go to meet the expert session, focus session. You can listen to the people, see their face, sometimes they are nice faces, listen to their voice and with specific accent. And we have also webinars. And webinars in general cardiology is a new event. It's case-based, based on the guidelines. It's very easy. You can look from your mobile, and you see opinion leaders interacting, sometimes a little bit fighting, and it's free of charge. Please join. And also you have the case. It's very easy. You go to the web, look to your scenario, and you may intervene, ask questions. It's interaction between the members. And then what happens? When in here we will see really the impact and the result of our guidelines. We have to evaluate the impact of our statements on practice and surveys. And the ultimate goal is to know if we improve the outcome of our patient. That is key. And after that, we have to promote, it's crucial in the domain of our disease, we have to promote research clinical trials. So, my friends, now what we have to do is to work and work again. I'm sure we'll be able to do that. So thank you very much for your attention.